Hey folks, we're back. Let's look at Chapter 12, Injection and Drainage Techniques. So in general, 4 things happen during embalming. Injection of the arterial solution, distribution of the solution through the vasculature, diffusion from the vasculature to the cells and tissues, and then drainage. When this actually happens, sufficient fluid is delivered. If you've mixed your punch right, adequate preservation occurs, discolorations are removed, moisture balance is achieved, and you have viewable remains. Injection involves a pressurized injection apparatus, the arteries for delivery, and the veins for drainage. In the unautopsied body, the ideal artery for injection is the aorta, but in adults, its location is impractical. The best location for drainage is the right atrium of the heart, but again, because it's surrounded by your rib cage, the location is impractical. So we try to use vessels as close as possible to both. And I know there's that one person in the class right now jumping up and down going, oh, me, saying, you can do a heart tap, you can do a heart tap. Yes, you can do a heart tap. Good for you, drainage. But realistically, not many people do a heart tap. Mechanisms that reduce the exposure levels to hazardous chemical vapors during embalming are good for you. So we want to try to find the best practices. Now, a heart tap is an ideal way to drain the body if you get good at it. One of the ways you can get good at it is by practicing it on bodies right when you start your aspiration. And after you've done about 30 or 40 bodies where you can hit that spot every single time, you're probably ready to do it on a paying customer. So examples. Good vent system. Ventilation draws fumes away from you. You know, formaldehyde is a heavy gas, goes down towards the ground, so have it pulled down. Good supply of incoming fresh air. Put those on top. Fresh air pushes down, forcing the formaldehyde low while the vents suck it in. Everyone's happy. Don't be dropping your chemicals everywhere. That's usually bad for you, especially if it's cavity chemical and you're using something really good like PowerCav 50 or PowerPact. Yeah, you'd spill that by accident and you watch all the first-time embalmers run for the hills. So gently mix your embalming solutions. Don't splash them. Be careful how you pour. Pour against the side of the tank. Keep rate of flow in the embalming machine closed. Close stopcocks, removing the hose and arterial tube. Don't let the stuff drip. Rinse it out. Clean it up immediately. Obviously, don't have a broken down, beat up old ratchet machine. Okay? Make sure you're replacing your gaskets. If your embalming machine starts leaking, colored fluid, it's probably a clue that one of the gaskets getting old and brittle needs to be replaced. And obviously, if it's just a rag-sacked piece of crap old hose that is falling apart, you're having to trim the ends off of it, trying to keep the slip arterial tube from falling out, probably need to buy some new hose. And you know how expensive that is at your favorite improvement store, right? It's like $3 for 20 feet of it. Rinse fluid bottles, empty into arterial solution. That's an important one because if you are pouring the bottle in, especially if you forgot to shake it, you probably want to fill it with some water, swirl it around, get all the good stuff, and then pour it back into the tank. Cap all bottles when you're not using them. Keep lid on the embalming machine. Use continuous aspiration of cavities during autopsy embalming, and clamp anything leaking. Restrict drainage as much as possible after blood discolorations have cleared. One, it helps the body retain the solution and lowers the volume of chemical and waste. Close drainage, okay? Attach draining tubing to a drain tube. Not a big fan of them. I have used them. Or you can do the heart tap, the direct heart drainage. Cover your waste sink to reduce splashing and aerosoling. Use moving water on the table. You should be doing that at all times anyways. And avoid high water pressure to reduce splashing. You don't want to have your table water blowing at a garden hose rate. Arteries are used for injection because they don't have valves. Okay? Embalming solution does not enter the heart. As soon as you start pushing in fluid, the aortic semilunar valve closes and pushes its way through the arch of the aorta. Central point of arterial distribution. The central point of arterial distribution, I've said it twice, this means it's important, is the arch of the aorta. The central point of arterial distribution is the arch of the aorta. That is insanely important. Criteria for which artery we're going to go reaching for. How big is it? Because we're going to want to use the biggest injection tube, arterial tube possible. Well, is it a good idea to be reaching for its accompanying vein? Where is it? Is it deep? Do I really have to dissect deep into the body or have to go through bone to get to it? Is it flexible? Does it have a lot of branches, which might mean I raised the wrong thing? If I do use this artery, when I'm trying to put the body out for in viewing, where is that incision going to be and is it visible? If it leaks, is it going to be visible? And how close is it to the center of distribution? The vein, same exact type of thing. How big is it? Bigger the vein, easier it's going to be to drain. How close is it to the right atrium, the center of drainage? Discolorations of the face and neck, okay, because if it's big, that allows me to get some of that stuff out. Ease with which the vein can be brought to the surface, yep, so how deep is it? All these sort of things come into play. So the one point, the holy grail of arterial injection, the one point. Injection and drainage from one side. The most common injection sites for a one point are the right common carotid and the internal jugular vein. Also, we try to use the right femoral and accompanying vein. So the carotids and the femorals, specifically the right common carotid and the right femoral. Historically, back in the Civil War era, the axillary was the most commonly used since the head could be cleared and the incision hidden very well. It's in the armpit, boom, done. Drainage was taken by the heart tap. Split, injection from one site, drainage from another. What starts as a one point can lead to a split. Right internal jugular with femoral injection is the most common. And generally, if I'm going to have problems, I know what some people say, well, why are you going to try to, make an incision up top and have to cut the person twice? Hey, is what it is. But this is textbook, man. Back off. I really like this because this allows me to really clear the head nice on both sides. Generally what I will do is I'll start with drainage in the femoral area. So I'll get my drain tube or forceps into the femoral vein and see how things go. And if you have mastered the heart tap, Jay Rhodes of the Dodge Chemical Company, he's alumnus of Miami-Dade College, great guy. He comes here, he does workshops for our students. I can't thank him enough for that. He is pro of the heart tap. I mean, this guy can just walk in, grab a trocar, and bam, it's done, and he's on to the next thing. It's amazing how quickly he does it. And that's amazing with injecting a femoral, because at that point, there's no incision in the upper torso. It doesn't really matter what the family brings in regards to the upper torso clothing. It is obviously going to matter if they bring in, like, a Speedo swimsuit and decide that they want to have the body view with nothing but, the Lido one, because that's going to be awkward with the incisions in the hole you just made. The multi-point, the oh my God, are you kidding me injection. Injection at two or more sites, okay? Used when fluid does not distribute properly to the body. Can start as a one point, maybe start as a split injection, and then becomes multi-point. As soon as you go to two or more sites, so technically if I've started the carotid and then I have to go to a femoral, I don't have a split. I have a multi-point. The book provides the example of injecting a femoral, then using an axillary to inject the arm, then using an ulnar to inject the hand on that arm. That already sounds like a lot of fun that I want to try to avoid. Restricted cervical, injection of both common carotid arteries, injection of the head separately from the rest of the body. And this is standard practice in some funeral homes. It is standard in the U.S. military. Restricted cervical, not hard. You raise both carotid arteries, the right and the left. You open the left, okay, open the left up, and tie the top portion off. With the right side, that's where you're going to do your injection from. The whole point is your arterial fluid never enters the head until you are ready for it to do it. Now, there will be some collateral circulation when you're injecting that will creep up the back of the head, but not enough to cause swelling or anything else. This is really, if you are going to anticipate issues, this is what you probably should be doing, and just, boom, accept it. Inject the trunk first. The whole concept of injecting the trunk, the extremities, the legs, is to make sure the fluid works. And you might need to hit the body with a higher solution or even a less solution, concentrated solution, depending on what's going on. If your head is decomposed because the head is all swollen, was left, and all the fluid and blood gravitated in because it was below the center of the body, You're going to want to raise the head, open the arteries, inject the body normally because it shouldn't have a lot of negative effects in there. Then reverse the thing and then treat the head separately for the decomp and the swelling and everything else. Restricted cervical affords the greatest control over entry of the arterial solution into the head. It's useful in normal unautopsy cases, bodies with facial trauma, and just about anything that has a complication. By the time you're done reading this textbook, restricted cervical is going to be the go-to injection method for anything other than your standard 1-point. Gives you all the advantages of restricted cervical, advantages for carotids and blah, blah, blah. For the most part, it's everything we just talked about. The 6-point is the injection of all the major arteries of the body, the right and left carotid, the right and left femoral or common iliacs, which are just above it, and the axillaries. It says subclavian or brachial. Way to kind of remember this, especially if you're looking at it on a professional assessment or a classroom exam, is that both things going into the head, the carotids are almost always there. Then look for the 2 arteries of the leg, iliacs or femorals, and look for the 2 arteries that feed the arms directly. So that could be the axillaries, the brachials, the subclavians, etc. It's useful for bodies where it's just going to be an absolute mess. There's like a whole laundry list of possibilities. It's kind of common sense. If it's going to be extremely complicated, it's probably going to be a 6-point. Mostly you do this on a autopsied body because we have all of those arteries readily available. We have no central vasculature because an autopsy happened and the central vasculature is all gone. And also allows us to put different strengths of solutions in different areas, which could be important. To be a true 6-point, you're going to have to raise all the arteries, open them all, inject them separately. And the order of injection, this is important, right then left leg. So legs first, right and left arm, arms next. And then finally, left, right on the head. Right, left, left, right. Always remember the head is different from the others. And you can take drainage from the internal jugular into a heart tap. You can even aspirate the body prior because you're not relying on the internal vasculature to actually distribute the fluid. You're going to inject it all separately so you don't care. And if you really want to be hardcore and earn your merit badge, you can do the 12-point, which means every place that you have raised, you inject both distally and medially, or inferior and superior, or lateral and medial. You inject in both directions, depending on where you're at. Often, embalming necessitates the use of large volumes of embalming solution. Jugular and femoral veins allow for more drainage, so swelling can be reduced when injecting large quantities. Some embalmers drain sectionally when embalming sectionally. That just sounds like all sorts of fun I don't want to do. 3 major injection sites: carotids, femorals, and axillaries. Head, legs, armpits. Injection tube should be as large as possible to fit into your artery without actually disturbing the interior of the artery, called the intima, or the tunica intima. Diameter of the tube greatly influences volume and velocity, which is why you want the biggest one possible so you can put in the most amount of fluid at the best pressures possible to achieve best preservation. Ancillary, it also cuts back on your time because you can inject more. So review the differences between our arterial and femoral injection. Essentially, this is carotid versus legs. And always direct drainage towards the heart. So if you're up top, you point the angular forceps or drain tube down. If you are in the arms, you point them in. If you're at the legs, you point them up towards the head. Short circuiting, well, this is the greatest disadvantage to a 1-point, or injecting and draining from a same spot. Can account for over-embalming of an area near the injection site and a loss of a great amount of solution through drainage. Coagulant can be pushed and block arteries. Unrestricted drainage can also cause this. And it's because fluids follow the path of least resistance. You push it in, it hits a resistance, and it will look for anything in any way possible around it. Skin areas surrounding the injection and drainage points frequently receive a greater amount of solution issues because of issues with pressure. When only the skin and superficial portion of the body and not the deeper tissues receive solution, we get shell embalming, which means the body will rot from the inside out, which means you will end up in court. Massage, manipulation, restriction of drainage will all help with this. In the next chapter, we will talk about more ways to help you with that. So, instant tissue fixation. And right now, of course, there's always that one student who's like, oh yeah, the head freeze, yay! Okay, yes, it's known as a head freeze or the face freeze. When I talk about doing something like this, I usually refer to it as like nuclear waste of the head, because you are pushing quick, pushing hard, and pushing strong stuff in an attempt to make things happen quickly. So for the most part, you're going to use restricted cervical injection when you're nuking a head or doing the instant tissue fixation. A small amount of strong fluid is used. That means you should be reaching for 25 index or higher, something fast firming, because you don't want the head to swell. Can you do it with medium index? Yes. Choose a medium index fluid that has some type of fast firming action so that you are not going to swell. It's useful when you have issues like swelling already, you have trauma or decomp because you're trying to get in as much as possible with a minimal amount of swelling. Little drainage is taken because you're only pushing in a small amount of fluid. It does say 25 index or higher. I am telling you, you should reach for that. You can do it with less, but why would you want to? It says you can inject waterless solution. I would hope you would, because you're putting as much fluid as possible into a bad situation. Don't need water. Potential pressure should be 20 when mixing solution in a centrifugal pump machine. So you should have fairly high pressure is what it's saying. Use pulse injection. Book says to turn machine on with pressure at 20 and flow closed. This then turn all the way open and close again. Keep this going until fluid is injected. So mind you, I want to state something here. This is not a bad way to get pulsation. There are different ways to get the pulse effect on a machine that doesn't have pulse effect built in. What I am going to tell you is that by jacking things on and off, especially like an on-off switch, okay, you can hurt the pump on the machine. Using the rate of flow is probably the next best thing you can do, and probably one of the easiest things you can do is just have a stopcock in the line and turn the stopcock open and close. So be aware that's probably one of the better ways for you to create pulse if you can. Suggestive solution is 16-ounce co-injectant, 16-ounce water, 1.5 ounces of dye, and 16 ounces of arterial fluid. So what you're looking at essentially is a near waterless solution. If I'm doing a face freeze, I'm probably going to be doing something very similar to what they're explaining, minus probably the water. I might just use a water corrective or a second bottle of co-injection, but that's just me. Surgeries, partial autopsies, etc., blah, 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 may result in variations of different techniques. Well, obviously, you're going to react to what you see and do what you have to do to get the job done. That's part of the charm. It's why embalming is an art and a science. When you're looking for vessels, remember the lumen of arteries remain open when an artery is cut. So if you see the hole stay open, life is good. If you cut something and it disappears, it was probably the vein you were looking for. Lymphatic circulation originates as blind end tubes called lymph capillaries, and it's located in spaces between cells. They're larger, they're more permeable than blood capillaries, and they converge to form lymph channels called lymphatics. Lymphatics have valve-like veins. They have lymph nodes along their routes, not their roots, because apparently I can't find the E key. Lymphatic fluid eventually enters the blood system by way of the thoracic and right lymphatic ducts. The thoracic duct empties into the junction of the left subclavian vein and left internal jugular. The right lymphatic duct empties into the right subclavian vein and the right internal jugular. Oh my God, Finn, really? So what is this saying? You got these little itty-bitty things in the tissue spaces, and they basically form drains for the tissues. These empty into larger areas called nodes, which then push them into other areas, eventually dumping them in the upper chest area so it can be filtered and processed. Otherwise, you'd be relying on everything going in and out of your capillaries, which is why the lymph is composed of fluids that pass from the blood through the walls of the capillaries, as well as everything else in the tissue space. Excess interstitial fluid enters the lymph system, becomes lymphatic fluid. So while tissue fluid is in the cellular spaces, the tissues themselves, it is interstitial fluid. Once it flows into the lymph, it now becomes lymphatic fluid. In death, The microbes go nuts in the lymph system. And the reason why they go nuts is because unlike your circulatory system, there's no blood. The white blood cells are not. Once things are in the lymph, they pretty much have carte blanche to do whatever they want because there's really no way for anything to get there until they re-enter the venous area where blood will then react with it again. Embalming solution diffuses in the lymph in this order: lymphatic capillary, vessel, major node. Back to a vessel, which transports it to the lymphatic trunk and then into the veins for disposal. So drainage. Drainage is brought about by displacement. We push something in, it pushes it out. Now, this number is arguable. It seems that it is arguable in every medical text I have tried to look at. It is arguable on any Google or Bing search. I don't care. This is the number you use. 5 to 6 quarts of blood in the average body. It accounts for 8% of all body weight. Do not confuse this with water weight. At death, there is this wave contraction in the arterial system, forces the greatest volume of blood into the capillaries and venous portions of the vascular system. It's estimated that 85% of your blood at death is in the capillaries, 10% in veins, 5% in arteries. Variations obviously occur because of outside factors. Drainage is everything we've seen: blood, blood clots, interstitial fluid, lymphatic fluid, embalming solution. Well, Professor Finn, you said interstitial fluid becomes lymphatic fluid. Right, but you're going to see in the next chapter that when we're pushing solution through the capillaries and into the tissue spaces, that it's a two-way street there. Some lymphatic fluid will flow into the capillary and then follow the route out as drainage. Anything that stays inside comes out via the lymph system. Only the arterial solution that passes through the capillary and flows into the tissue spaces are retained. Anything else gets flushed out via drainage. Color and consistency of drainage change during injection, and this is important. Earlier drainage is dangerous, more dangerous than later drainage, because the earlier drainage is more blood. And all the stuff that is in the blood, the microbes, the diseases, all of that. All clotted material comes from the veins or from a heart chamber. That's important as well, because arteries get smaller and smaller and smaller, and by the time they get to their smallest point, they run and they block. So anything we are pushing out in the form of clots and drainage has to come from the other side as things get bigger and bigger and bigger. Postmortem coagula are not actual blood clots, but blood inclusions that become congealed and stuck together. And anyone who's worked in the prep room knows these things can be all sorts of large, dark, and disgusting. Postmortem clots are multicolored. Bottom portion is dark, formed by red blood cells. Clear layer on top is usually a jelly-like layer of fibrin. And antemortem clots are actually thromboses. Platelets, fibrin, an actual clot. So the only real clot, quote unquote, that we have is the antemortem in-life clot. Everything else is a formation of gravitation or congealing of blood. Viscosity can depend on cause of death, time, temperature, 1,000 different things. Volume of drainage is not equal to the volume of embalming solution injection. It should be coming in or out at probably at some point the same rate when everything evens off. But think about it. You're going to have drainage coming out. Large portion has to fill the arteries first, right? And then drainage is going to happen. So you're going to be pushing in at a rate, and then it's going to be coming out, and then it will kind of balance itself off, if it comes out at all. So as long as solution is distributing, it is getting into the body is reacting to preservative, and nothing is swelling or discoloring, drainage need not be a concern. So if you're not draining and the body's not swelling, essentially, quote unquote, continue to perform your embalming analysis, but you don't care because everything is ducky. So review the examples in the book as to why drainage may be aware. And you're going to love this. You can take drainage from the mouth if a stomach ulcer has ruptured large veins. It's just going to pour into the cavity, into the esophagus, and then come right out the mouth. And if it's coming from the mouth and nothing else is swelling and everything is preserving, again, continue to perform your embalming analysis, but it should fall into the category of you don't care because everything's happening. So when can good drainage be expected? And here's the laundry list. Interval between death and prep is short. Body still retains heat. Early evidence of liver mortars. Blood has just started to pool. Hypostasize all over the body. No fever or blood infection to coagulate the blood. No skeletal edema. If it is present, that's water. It helps dilute things. Body is jaundice because, again, the body's tried to retain water, probably combat the jaundice. Treatment with blood thinners, that's the favorite one. We love it when they shoot you full of heparin. Man, that makes our job easier. Body refrigerated shortly after death, but not for a long time. Been in cold storage for about 24 hours. Death was due to carbon monoxide poisoning because that retains the blood in a liquid form. So why do we drain? Well, we're pushing fluid in. It needs space. And if it doesn't come out, it's going to swell. Reduces secondary dilution and all. You can read those on your own time. Drainage makes room for the arterial solution so it can be evenly distributed to all tissues of the body with a minimum amount of swelling. Center of drainage is the right atrium of the heart. Remember what the center of distribution was? Equally bloody important, right atrium of the heart. Right atrium is supplied by the superior vena cava with blood from the head and upper extremities. The inferior vena cava supplies blood from the rest of the body. Right internal jugular can lead right into the right atrium, which is why we like to use it for drainage, and we put our drainage instruments into it. After death, blood quickly congeals in the right atrium. Some embalmers use two locations for drainage, above and below, jugular and femoral. You can. It's nice. Doesn't matter. Not going to affect anything in the grand scheme because all the pressure's on the arterial side. So you can actually use multiple sites for drainage, and it's actually better for you. Primary drainage site is the site where drainage is first taken. So your fact pattern there is they're going to throw a word problem at you. You probably, injected from multiple sites, you've drained from multiple sites, and then they try to be cheap and they say, where is the primary drainage site? And you go to the last one because that was where drainage was best. No. First place. And any vein can be used for drainage regardless of location or size. We could even use the little venae commentantes, the ones that run along the side of your radial and ulnar artery if you wanted to while you watch the body inflate. But generally we want to go for the biggest one closest to the right atrium. And I love groove directors. I love those tools. They are the instruments with the aneurysm needle on one end and the groove director on the other. Oh man, those are my go-tos. I love those things. And don't be afraid to use tools. People bash me because like, Pastor Fan, you've been doing this long, you still have to use a groove director. Yeah, because it makes my life easy and I don't have to screw around and rip things. So laugh all you want, man. If a vein tears while being raised, tough crap. All right, moment done. Force as much blood as possible from the vein. You want to try to get as much out as possible. You try to see it again. Clean the area with absorbent material so you can try to find it. When you see where the blood is leaking out of, which if there's a lot of pressure behind it, there's going to be a mess. It's going to take a while. Clamp an edge of the wall of the broken vein with a small serrated hemostat. Basically grab it across the entire vein and then try to get your drainage in there. Do not remove the hemostat if the vein is in two pieces. So basically, you want to be able to grab the vein at any point, and after embalming, pass ligature and tie off the ends. Right internal jugular is the most valuable drainage point in the unautopsied body. If you want to do a heart tap, well, here's how you do a heart tap. Attach a clear plastic hose or a trocar with a sharp tip. And when they say sharp, they just don't mean a tip. They actually mean a sharp tip. If you're not sharpening, you need to sharpen. If you're using, one of those black replaceable ones, replace it if it's rusty and put a sharp one on there. Inject a gallon to a gallon and a half. It needs pressure. Charge the system. Insert at standard point of entry, 2 left, 2 up. Draw an imaginary line connecting the left anterior superior iliac spine and the right ear. You should be familiar with that. Okay? That is the guide for the right common carotid. Direct the trocar toward a point where this line crosses the right side of the sternum. So you're going to kind of eyeball this and hope you're where you're at. Keep the trocar slightly right to the sternum and kept in the anterior port of the mediastinum. If you use a hydroaspirator to assist you in a heart tap, use half suction, and as soon as drainage starts, shut it off. The heart will push it out by its own. Practice this by doing this first during aspiration. Okay, so the whole concept is that you finish the body is charged, and then you go in there. I mean, you've injected like 3 gallons, it's going to be charged. Go ahead, direct your trocar towards a point where that line crosses the sternum, and then keep it slightly to the right, and pop goes the weasel. Here's the aorta. Congratulations. You went from a 1.6 point trying to do a heart tap because the aorta is the biggest artery in the body. It's just going to flow fluid into the cavities and do nothing. Remember, drainage is inserted towards the heart. Use a groove director. If you use one, insert it first prior to the drainage device. It defeats the try to put the groove director in something you've already found. And do not force a drainage device. If it's not sliding in easy, just sit there and work with it. It is what it is, or just accept it's not going to go in all the way, and keep it open where it is. If you use a drain tube, you may have to lubricate the plunger rod with massage cream that helps it slide in. Open that up and clean it after every use. Those get icky quick. Drain tubes for jugulars are relatively large in diameter and short in length. There's a ton of drain tubes out there. There's some pictures in the earlier half of the book. I think it's chapter 3. Know the differences, and you can see them very clearly between a jugular, a femoral, and an iliac. The jugular is the shortest, the femoral is the longest, and the iliac is curved. So what are the advantages? Drain tubes. It's a finite size, and it will retain the vein at a finite size. If there's something does come up to block that tip, you have the stirring rod, which helps break things up and pull it through. Drainage can be shut if you close the tube, and you can build up pressure to assist you with distribution and diffusion. And if you want, you can run a hose right down the drain, attach it to your drain tube, and nothing drainage-wise ever touches your table. So why do these proverbially suck? Well, it is a finite size. If it's bigger than the diameter of the tube, you're going to have to break it up with the stirring rod, and if that doesn't work, it's not going to come out. You can't grab coagula. If you're pushing the tube in, it can block other portions or other tributaries of the vein trying to drain. Tubes are not exactly flexible, so they might mark the face or interfere with positioning, and you can easily push through a vein into a body cavity, and the drainage goes there instead of coming out. So the angular spring forceps. What are some advantages of this guy? Very large opening for drainage. Well, yeah, in comparison to a drain tube, they're huge. Head can be positioned. Certainly, you can put the drain tube or the arterial tube, angular spring forceps with the angle back down away from the head and do whatever you need. You can actually grab coagula. If something gets there, you grab it and pull it back, and it'll push itself out. Does not block veins. Doesn't have holes. Things can go around the 2 prongs. Disadvantages. Well, may need to be removed for intermittent drainage. Drainage can splatter. Oh, yes, it does. And embalmer's contact with drainage is increased. So, number 2 and number 3, in my opinion, are just basically whiny crap. It's messy, but what we do is messy. And it says may need to be removed for intermittent drainage. Obviously, this person never thought about just taking their finger and sticking it into the open hole and blocking it. So you can have intermittent drainage. You can't really have alternate drainage. You could sit there and kind of hold everything shut and then turn the machine on and off if the machine is in an easy area for you to reach. But in most places, that's usually a little bit difficult. 3 types of drainage. We've been talking about these throughout the different lessons. Alternate, concurrent, and intermittent. So, alternate, really simple to remember. If you are injecting fluid, you are not draining. If you are draining fluid, you are not injecting. More uniform pressure is achieved because everything's kind of doing its thing right. More complete distribution because it holds more pressure. Fluid diffusion is enhanced, pressure filtration is increased, but, oh my God, it takes more time. You're going to be in the prep room all day. What are we paying you to do in there? Yeah. Bitch. Increased risk of distension. That's the problem. So even though it takes more time and there's some perks to it, the increase in swelling from this kind of might outweigh it. Concurrent or continuous drainage. It's hard to get pressure on one side when you're allowing basically the body to short circuit. That being said, we've been doing this for probably, at this point, nearly a century and a half, and it really hasn't been an issue. Clots may not be dislodged. Well, I know that is a decomposition issue, but if the clot ain't moving, then that's a good thing for distribution, right? Short circuiting can occur, and that's the huge problem. With concurrent drainage, short circuiting is highly, highly likely if you're not doing your job right. May dehydrate and wrinkle body tissues because everything's flowing out too quick. But it's useful when edema is present to encourage hydration because it does dehydrate. And the last one, intermittent, it's simple. While you are injecting, you shut off drainage now and then. Stop drainage until certain amounts of fluid injected or surface veins are raised. Ensure surface blood discolorations are clear before intermittent drainage begins because you don't want to force any of those products where they don't belong. Less time-consuming than alternate. Encourages distribution and filtration, helps prevent short-circuiting, and recommended with colloids. Recommended with colloids to slightly distend emaciated facial tissues. So if we are doing this, it is recommended that we do it for emaciated or cachexiated bodies to help things swell out a little bit and hold water in. As soon as you see any type of swelling, stop injection regardless of the drainage type. You really don't want swelling, even though it just said right here that you want to slightly swell emaciated facial tissues. You figure that one out. Techniques for improving drainage. Well, pre-embalming, use the biggest vein possible. Find the largest drainage instrument. Injection of a pre-injection fluid to kind of charge your system. And take off as much intravascular pressure as possible. While you're embalming, use your drainage device, your stirring rods, or your angular forceps out. Use a massage and pressure to move venous clots, increase rate of solution injection, rate of flow, or increase injection pressure. Use intermittent and alternate forms of drainage rather than concurrent, or use another drainage site. Disinfection, remember, that first stuff that comes out is the most nasty, the most hazardous. Arterial solution will disinfect it to some degree, and once it enters your fluid system, it's mixing up with all the other really bad garbage in there that can kill you, so it's going to be even more diluted. Minimize contact using closed drainage. Use a drain tube, run it down there. If you're using angular forceps, make sure you have your table water right over this place where the drainage is coming out, and it's rinsing itself off. It also bears mentioning at this point that if you are using it where it's coming down and coming over the face, keep blood off of the face. You don't want it to discolor the face while you're injecting. You can disinfect drain blood by draining it into a container. So you put down the old 5-gallon tank there. Add 1.5 gallons of fresh household bleach. You can pretty much just note to yourself, if you add 1.5 gallons of bleach to anything, it is going to kill it. Cover the container because sniffing bleach for 1.5 hours isn't a great idea. Let it sit for an hour. Carefully pour it down the drain and then flush the drain with running water for 10 minutes. Hey man, do what you're going to do. This may be protocol when you're doing certain CDC cases, but for the most part, we're not going to collect the blood and then pour bleach into it. That's almost a waste. Because once it gets to the sewers, it's going to be treated anyways. Oh, Professor Finn, look how nasty that is. It's going right into the sewer. Obviously, you've never thought about what goes down the drains at hospitals. Injection of strong arterial fluid, waterless, at a very low rate of flow with little to no drainage taken and closed drainage. Aspiration is delayed as long as possible. If the face discolors, a very limited amount of drainage can be taken. Essentially, you're not taking any drainage. Folks, thank you for paying attention. We will see you in the next lecture.